Hello, Mansi ji.
Sir, good evening. Good evening.
Vinayak, right? Vinayak.
Yes, sir. Vinayak, sir.
Vinayak. Okay,
Yes,
Vinayak.
sir.
Okay.
Sir, should I make you the host, sir?
Yeah, I'll share the screen. Polls are on, right? Polls are on.
Yes, sir. Polls are on, and we are right now live on YouTube, sir. So I am making you the host, so you can schedule the post. You can use the poll.
Okay.
Okay, sir. So now you are the host, sir. So you can use the poll.
Okay. Okay. Is my screen visible, Vinayak?
Yes, sir. Your screen is visible, sir.
Just the PowerPoint, right?
Yes, sir. The PowerPoint only, sir.
Oh, good. Okay. So polls. Why can I can't find the polls actually right now.
Sir,
Polls are not visible.
So there will be they will there is an option for more. You can click on that and you
Now
can.
it's visible. Now it's seen. Okay.
So should we start the room?
Yeah. It's already late actually.
Yes, sir.
I was in the hospital. Just came right.
Okay, sir. From your end, now you are the host, sir. You can start the room, sir.
Start webinar.
Yes, start the webinar, sir. Yeah.
Okay. So, but parts.
So the webinar has been started, sir.
Okay, fine. So now it's streaming live in the YouTube.
Yes, sir. Now we are streaming live on YouTube, and the room is open now. The attendance will be visible.
Oh, great. So, good evening, everyone. Welcome to the 17th module of the Fine Neurophilia series. So we'll be going today to a very important topic, that is epilepsy. It is actually a subspecialty in itself in case of neurology, because we have postdoctoral fellowship in epilepsy. It's a vast topic. We have epilepsy surgeries going around in the world. So many questions from epilepsy are short in the coming entrance, especially in the institute entrance as well as in the NEET, as you have seen in the previous repeats. So I tried to finish it in a single module, but it's not easy because 20 questions we cannot cover the epilepsy as such. The main thing is not covering the epilepsy or the any module as such in a single video or single lecture. The main thing is you have to go back and read the Harrison part. So before starting, I would like to thank the Fine series, Fine faculty, especially Sudhir Kothari sir, Vinayak, and all the faculty here for giving me this opportunity to converse with you and interact with the MD students who are aspiring to be neurologists. So before that, I will be happy to announce that all the people who are following the Fine can actually confidently continue following Fine Neurophilia series, even if they are not following any coaching class or entrance learning apps. Because even with this and with few tests and all, most of the students who are following this and following me are able to score good ranks in the institute exams. And it's out of the top 10 ranks in the AIMS this time, April. That is the first exam which they have conducted in 2021. That is AIMS. And now after that, PGA was over. We had out of the top 10, 8 were our students. And last year also it was, we didn't advertise it or anything because we are not an app or anything. We are just a teaching session with lectures by faculties. So we had 33 in the top 100, all out of 6 in Sri Chitra. Actually 14 out of 16 in NIMHANS, not 4 out of 6, sorry, and 6 out of 14 in the AIMS, and many more actually. So I mean, so just I told you all this not to advertise or boast or anything, just to make you confident that first thing is you have to learn your textbooks thoroughly, first and the foremost thing. There is no substitute for that. Whatever you follow, whatever, but mock exams and all you need to do, that is for sure. But after studying the textbook, you have to have some MCQ orientation of what you have learned. So that is why these kind of modules help you. And how far we have come here in fine neurophilia after starting it in December is this kind of 11 modules, which don't want to repeat because I have repeated in the last class. So straight away we'll go to the epilepsy module. Epilepsy, you can try answering this question. So I had, as in every module, you must have studied this, at least read some part of Harrison and Bradley before coming and attempting the module. This is actually a what kind of experience of attempting the MCQs, because in front of your phones, mobile phones or laptops, you have this option of answering these questions which I am putting you through. So try your best to give an answer, because don't jump an answer. You have ample time to answer. Just give an answer after reading. So this is actually a practice session for you also. So you write after first go through the questions, structure of the question, each part, very important. Then go through the MCQ options. So here we have, for starting the session, I had put this question: which of the following is a correct statement according to the latest ILAE, which we are following? As you know, ILAE has been changing the classification, the definition, and all for long. So that is very important because they can ask in your exams. And the MCQ, these options here are: one is at least two unprovoked seizures, which are 12 hours apart, or whether it is a single unprovoked seizure, which is actually having a 60% recurrence after over next 1 year, or is a diagnosis of epilepsy syndrome, or all the above. So most of them have answered that answer as all the above. You may think that all the above would be the most common answer, because that is actually suggested by most of the short, like what you call shortcuts in MCQ answering, that all the above or none of the above could be the answers. But you don't expect that in case of an DM entrance exam, because that usually won't be. So after reading through the questions, you should understand that all these are actually structures for a definition for epilepsy. Actually, all these could be. But the thing is that two unprovoked seizures occurring 24 hours apart actually could be diagnosed as an epilepsy. So you should understand that seizure is different, epilepsy is different. Seizure is a single episode, and to be termed as an epilepsy, we have to have at least two unprovoked seizure or a reflex seizures which are 24 hours apart. Or if a person is having a single seizure, and if you think that there is a seizure risk of about 60 percentage over 10 years, and not just 1 year, over 10 years, then it can be termed as an epilepsy. So in a general population, after getting a 1 year one time seizure, the usual risk calculated is about 60 percentage. So this has been given as a breath of air for the treating physician. If he thinks that a patient coming with a first seizure, if he thinks that the patient is has a high likelihood of having a second seizure in a 10-year, he can actually treat the patient with anti-epileptic drugs. That is one. So he won't be medico-legally implicated. That is one reason why they have put this in the criteria. And diagnosis of an epilepsy syndromes. You know about the various epilepsy syndromes. Not only in childhood, even in adulthood, we have epilepsy syndromes which are there. So all the above is not the answer here. Only possible is diagnosis of an epilepsy syndrome. Definitely, we can term it as a seizure disorder or epilepsy or seizure disorder. But the others, there are slight changes. One is this 12. It is not 12 hours, it is 24 hours, and it's over the year of 10 over 10 years and not 1 year. So remember that. So seizure is just a transient event when there is a large amount of electrical activity coming from one part of the brain. If it's coming from a one part of the brain, we call it as a focal seizure. Previously, we used to call it as a simple partial or a complex partial seizure. And if it comes goes and entirely suddenly to all parts of the brain, we call it as a primary generalized seizure. So that is the term for seizure. So seizure is classified as focal, generalized, and unclassified. And you know that to term it as an epilepsy, we have all these three sentences which we have previously studied. So now itself by heart these three sentences. So as we have seen, to term it as an epilepsy, we need to have these kind of these definition criteria fulfilling this definition, that is 24 hours apart and 10 years, and diagnosis could be of an epilepsy syndrome. So what is the risk of seizures after two unprovoked seizures? What do you think is the risk of seizures after two unprovoked seizures? You can this question I have taken from Bradley. Yes, definitely. So that is the reason why they have to put the term 60%. Even if a single seizure having a 60% recurrence, you definitely have to treat. But definitely two seizures definitely have more than. That is what the studies say. That is the chance of recurrence is actually 60%. These are all simple things you have to know that has got practical implications or clinical implications. So that is the reason why they could be asked in the future entrances. This is in Bradley 8th edition. So now let's see this. So a 6-year-old girl came with seizures with semiology of stiffening of left upper limb and lower limbs with deviation of face to the right side with blinking of eyes. You can see the patient's face, I suppose. And on questioning, she was answering. She was telling her name, which class she was studying. And it lasted 2 seconds. You can see the eye blink. I am talking to her and she's talking, telling her name and everything. So according to ILAE classification, this falls under which seizure type? So we are now talking about the seizure type. So you are in your exam, the same question would be like this. No videos would be given. If you want to see the video, I will show you the video again. So, I am asking the name. She's telling her name, which class she is studying. She's holding her mother with the right hand and moving, but there is stiffening more on the left side. So that is suggestive of what? Okay. If you have the answers with you, you can give in the polls. It's question number 3 we are trying to answer. So is it a focal impaired awareness seizure, focal aware seizure, a simple partial seizure, or a complex partial seizure? Okay. So the thing is that in this patient, you have definite idea that after seeing what we look in a patient, what we see in a patient is termed as a semiology. What we see. So always in the clinics and even the neurologist or physician always ask you to describe the semiology of seizures. So in semiology, describe what is being seen by you. So in that patient, you have seen that the head is turned towards the right side and the patient is having stiffening of the left side of the body. Head is turned towards the right side. So it's kind of a focal thing. And as you know, the patient is aware. The patient is talking to us. Patient is telling her name, where she is studying and everything. So it's aware. So previously, if it was called, we would have told that as a simple partial seizure. If it was 2010, I was taking this webinar, then we would have answered it as simple partial seizures. But now ILE has reclassified it as focal aware seizures. So you should know the changes. That is why this question. And if there was loss of awareness, that is patient lost her consciousness, she is not able to remember anything, and it lasted just 2 minutes, after which she recovered. So this is actually a focal aware seizures. So this is the latest ILAE classification. Don't get worried regarding what is happening with these colorful diagrams. It just says that first we had described what a seizure is, as asynchronous burst of activity from a certain region. If it is from one side, it is focal, otherwise generalized, and they have given room for something known as non or unclassified. And epilepsy types, actually, if it is having a particular number of time it's repeating, then it is becoming a seizure disorder or epilepsy. That is focal, generalized, could be combined or it could be unknown. And they have took into consideration the comorbidities which could occur, and also the etiological classification, as well as the epilepsy syndromes we have discussed in the first slide. So it is just these three things. And what the changes are, you can just see that what we had talked about, all the partial things have been changed into focal. Now we don't have the term of secondary generalized or focal seizure become secondary generalized, nothing like that. Focal to bilateral generalization is being used. And there was dyscognitive, simple partial, complex partial, psychic, secondary generalized, all has been eliminated. You can see these slides. So what changes were made in the 2017 classification from the previous one. So in this patient, we can say we had a focal onset. You know that it is one-sided, and the awareness was actually preserved, and there is motor activity. So it's likely that later it would have further developed into bilateral tonic-clonic. Then it becomes secondary generalized kind of thing. But we don't call it like that. It is called focal onset to bilateral tonic-clonic seizures. So focal onset can be aware or with impaired awareness. So what is the drug of choice for a focal onset seizure? You can put it in the chat box. I haven't put up all options. There is no need, because you all must be knowing. For focal onset, drug of choice would be definitely what? It could be either, yes, it could be either somebody, at least single person. Yes, it could be either carbamazepine or oxcarbamazepine. So after starting on oxetol, she didn't have any further episodes. It's the same patient. She didn't have any further episode. This is an adult patient who is also having focal aware seizures. So for this patient, it continued for long. It's continuing refractory to treatment. Oxetol was tried, multiple drugs were tried. So if it continues like this for a long, it is called epilepsia partialis continua. So it is continuing for a long time. So which of the following statement is incorrect regarding a focal seizure with impaired awareness? So this is taken from Bradley. You can try to, Harrison. So you can, if you have read, you can, or just read the question carefully. Question, nothing much is there. What is which of the following statement is incorrect, which is not true regarding focal seizures with impaired awareness? The previous patient, what we have seen is a focal aware seizure. Patient was aware. So if the patient having a focal seizure loses his or her awareness, what should not be there from the following statements, which is a wrong statement of the following? So as you know, focal seizures begins with an aura that is stereotypic for the patients. For that patient, the patient would be having aura. Usually, there will be an ictal phase, which is motionless stare, which marks the onset of the period of impairment. And impaired awareness is usually accompanied by automatisms. Automatisms are periodic movements or repetitive movements, which I'll discuss in the future slides. And post-seizure, there will be anterograde amnesia. So what is anterograde amnesia? Anterograde amnesia is something that patient is unable to form. So we know that in seizure, during a seizure, there is retrograde amnesia. Patient won't be able to remember what happened during the time of seizure. So we call to him, what happened, asked him, or what happened to him, he won't be able to remember. That is called retrograde amnesia. But immediately post the seizure, he also will be having anterograde amnesia. That is, he won't be able to form new memories for some time. And also he will be having something called as transient neurological deficit, that is otherwise called Toad's palsy. So he may have unilateral weakness or having a speech deficit or aphasia for some time. So that one of the commonest TIA or a stroke mimic which comes to a casualty is following a seizure. Patient with seizure presenting with Toad's palsy. So that is one more thing. So the answer here is post-seizure, there will be anterograde amnesia, and also the patient can have transient neurological deficit, especially when the patient is having focal seizures with impaired awareness. So usually there will be aura and impaired recollection or awareness of the ictal phase, that is retrograde amnesia. And impaired awareness is usually accompanied by automatisms. These automatisms are like lip chewing behavior, lip smacking behavior, or swallowing. The patient will be doing like this. He will be moving like after the seizures, or along with the seizures, the patient will be having the movement of the lips like that, and swallowing, picking movements of the hand, and display emotions. So that is another highly motor things, like hypermotor behavior can also occur, or manipulative behavior like that. And following it, it can mimic something like a stroke. So there will be aphasia, hemi-neglect, visual loss. If it's occurring from the posterior region of the brain, then the patient will be having visual loss. That kind of things can occur in case of focal seizures with impaired awareness. So studying this classification, you may think it's only for a neurologist, but you have to have some idea. So basic version of this is that focal, aware, and impaired. So it can then generalize and form focal to bilateral tonic-clonic. So FBTC, that is the last one. Generalized onset, that is motor, tonic-clonic, and non-motor, that is the absence one, and the unknown onset. So it has an expanded version, same thing. It is then Bradley. So just identify this. I have put, if you are following my Facebook, WhatsApp, Telegram, and other groups, I would have put the question just for your knowledge. So I am hyperventilating the patient, and for just for less than 30 seconds, I am asking him. He doesn't remember what happens, and he had kind of rubbing his hair, and he was unable to answer to my question. But immediately later, he answered. So what you may have expected one answer in this options, but I have not given it. So this is the fifth question, I guess. Identify the seizure type. So first is the focal aware seizure, focal impaired awareness seizure, focal to bilateral tonic-clonic seizure, or it's a generalized seizure. So this is one thing. Do not make mistake in this. I thought all will answer it correctly as expected, but few are making mistake. Yes, patient is aware, but patient is not aware, because as in the first case, when in the focal aware seizures, if you remember, while asking the questions, the patient was telling the answers properly. The patient was telling her name and class. But in this patient, if you have doubt, so the answer here is generalized seizure. It just means that in the classification I had told you, that in the generalized seizures comes the absent seizures. The generalized seizures comes the absent seizures. So in the generalized non-motor, when there is not much of a motor activity, we term it as a absent seizures. In the absent seizures, there are typical, atypical, myoclonic, eyelid myoclonia. In this absent seizures with eyelid myoclonia is otherwise called as the Jeevan syndrome. Okay, Jeevan syndrome. And typical and atypical absence are different based on EEG and clinical findings. Atypicality would be, in typical absence, the typical 3 Hertz spikes. Atypical would be having less than 3 Hertz spike. And there will be motor activity, increased motor activity in atypical. But it's not that the typical won't be having any motor activity. The typical will be also having a little motor activity, as seen in this case. So I'll show you the video again. If you can see, when after the hyperventilation, especially these kind of seizures, generalized seizures activates with hyperventilation and photic stimulation. These are the activation procedures. I am asking him his name. He is not able to answer. He's just staring at me, but he has not lost his tone or posture. He's moving his hands and following. You saw the rubbing of his head. So these are mild motor activities which are expected even in typical absence seizures. So the answer here was, it was an absent seizures which comes under generalized seizures, and it's not a focal aware seizures. I knew that some people would have confusion. So just reading the textbook, you may be thinking that you are just reading the theory. So just to make you acquainted with this clinical scenarios, I have put these kind of videos, so that next time you read the textbook, you will be more interested in reading the textbook and grasping the important parts from it. So typical absence are characterized by blank stare, motor arrest, lasting less than 15 seconds. If you see this video was less than 15 seconds. So the individual is usually unresponsive and unaware, and seizure ends abruptly as it starts. There is no much confusion. After this seizure stop, there is no postictal confusion. That is typical of a generalized seizure. But he must have missed the conversation. So that is the usual complaint. The patient's mother, mother going to a parent teachers meeting, and the teacher telling that the child has become inattentive. His notes, some parts are missing. That is the usual complaint. And mother will be also telling that the child is daydreaming a lot. That is the usual complaint we get. And this child, as you saw, this child also, after getting the seizures, after this academic year, he was having this online class. So online class with this video, that is photic stimulation. He was having increased photic stimulation due to the laptop videos and all. So that is the reason why there was aggravation in his absent seizures, it seems. And hyperventilation, easier method is just ask him to blow the paper, which I use in my OPD. So you can easily make out in our OPD the absent seizures. And typical absent seizures are diagnosed primarily based on the clinical features which I have told you, and the EEG finding. That is, it won't be the typical 3 Hertz frequency of EEG spikes, but it will be less than 2.5 spikes. So that was regarding the seizure types, that is focal, generalized, and unknown types. So in seizures, the abnormal motor movements may begin in a very restricted region, such as fingers. It will just climb up, march, gradually progress over seconds to minutes to include a larger portion of the extremity. This phenomenon was described by whom? I'll start the polls. It's a very easy question. So I expect everyone to answer. So after him, this phenomenon is named. So it is kind of a marching phenomenon. So it starts in the tip. So if you see focal seizures, sometimes it starts in the tip of fingers or legs, or sometimes it starts as a twitching of the one side of the face. So following which there will be deviation, versive motion of the head, and then it becomes generalized. So, okay. These all people I have mentioned are pioneers or legends in the field of epilepsy. Cahal, Penfield, Lennox. But Jackson was the one who described the typical Jacksonian march of seizures. Sorry, I didn't put the option. So William Lennox, Penfield, Huggins, Jackson, and Cahal. So abnormal movements, motor movements, may begin in a very restricted region such as fingers and gradually progress over seconds to minutes to include a larger portion. And this was described by Huglin Jackson's and known as Jacksonian march, and represents the spread of seizure activity over a progressively larger region of the motor cortex. So it starts from a smaller region and extends to larger region. So some patients describe odd internal feelings such as fear, sometimes the patient may present with epigastric burning sensation. They usually, we get references from gastroenterology department that the patient was having epigastric churning sensation alone. And that is the reason why they went for gastroenterology opinion, OGD scopy. And later, because the gastroenterologist has high index of suspicion, they had referred the patient to neurology because of suspecting seizures. So what do you think is this? And maybe sometimes patient have deja vu, and entend is related to hearing. So patient may have a feeling that they have visited the same place again previously. Even a new place, they may feel that they had that deja vu feeling. You know, the deja vu usual thing described. And deja intentive means have heard the same thing again, means previously, even though when they haven't heard that. And micropsia is small and macropsia large. And these subjective internal events are not directly observed by anyone else. And these are termed as, and these things are called auras, and they have got high localizing values. So depending on where these auras have started, or type of auras, we can sometimes localize the seizures. So if there is visual auras of unformed visual images starting, that is ill-formed images, flashes of light, etc., beginning in the beginning of a seizure, we can tell that these seizures, ill-formed, unformed visual images, flashes of light, etc., colorful flashes of light, etc., then we can say that these are actually from the occipital region. But if it is a formed images, then it is most likely from the temporal region. And if it's an auditory auditory auras, then it could be a lateral temporal region. So this kind of things, auras help us where to localize the start of origin of these seizures. These are auras. So some patients describe odd internal feelings. These are called auras. And these auras are actually kind of a focal aware seizures, because if they don't have this motor component to it, we can term it as focal aware seizures. And auras are typically short in duration and lasting some minutes. And some patients actually with seizures may experience a prodrome. So that are different, completely different from auras, and they are not actually not auras. They are actually a feeling of anxiety, fear, anger, etc. Even minutes, 30 minutes prior or days before, and that is something different from auras. And some auras may actually prolong for longer time. So you may think seizures occur only in humans, but it's not like that. Seizures can occur in all life forms actually. Even amoeba can have seizures, and even animals, as you can see in this video. So this is having a lion having a seizure. If you can see, this is a lion having, I suppose the lion is having actually intense fear, or I'll let you see the video first. Okay. So first question, you can put in the chat box whether it's a generalized seizure or a focal seizure. Simple question. Nobody is seeing, you can answer it. Yes. Yes, very good. Very good. Very good. Okay. It's actually focal onset seizure, right? So it's actually focal seizure becoming secondary generalized. As we are aware, we don't call it like that these days. We call it as focal impaired awareness seizures becoming tonic-clonic seizures. So if you see the video again, before the start of the seizures, the patient, I'm telling patient and patient again and again, it's actually the lion. The lion was having some kind of aura or a fear, or it could be something else. The lion is actually moving in a gyratory fashion. It is actually looking more towards the right side. It has head turned towards the right side. Usually head turn occurs contralaterally. Right side means it most likely could be if it is fear, the lion is experiencing fear. The fear factor usually as an aura occurs in case of a temporal onset of seizure. So that we were talking about aura, right? So aura, the fear of aura usually is a temporal, and the lion was looking towards the right side, then it most likely would be a left temporal onset of seizures. But and later it becomes secondary generalized. As we can see, the lion is having both upper limb and lower limb generalized tonic clonic movements, and that is the thing. But since the lion was moving round and round and round, this is could be a special type of seizure which is rare, that is otherwise called gyratory seizures. It's not interest of for you, but know that we can, based on the aura, we can actually uh, what localize the seizures based on the side, that is based on the head turn movement of the limb, based on the Jacksonian march, and also based on the aura, if it's in this intense fear, epigastric pain, other things. That I think I'll localization I'll discuss in the next class. Others will. So this is from Bradley I have taken. I am sure this would be a question in one of your coming entrance exam. This I'm pretty sure this will be coming. So if even if you don't know from this video, this session, try to learn it. Okay. Wrench. Wrench is an acronym connected with which one of the following? Wrench. If anybody is aware of the answer, what answer, it's automatism. What is the full form? You can put it in the chat box. I'll be happy to know that people are learning Bradley. Okay, difficult. It's okay. Okay, wrench. Actually, it's a type of automatism. So automatisms are repetitive motor activities that are more or less coordinated and resemble a voluntary movement, but are not purposeful. So when in the start of a seizure, the patient would be doing something, right? And if that seizure occurs and the patient is continuing that movement, if the patient is writing something or doing something, clapping or something, if it's moving, going on like that, it is called perseverative automatisms. But after the seizures, he is doing some other kind of automatism. It's called de novo automatisms. And the most common automatism which we see is called oro-elementary automatism. It means oro-elementary means something connected with mouth. So usually what we see is lip smacking, chewing, swallowing, and the rarer ones would be it'll spitting. During that time of seizure, patient unknowingly starts spitting and may have gestural automatisms. And one of the non-manipulative upper extremity automatism tends to be rhythmic and it's not related to anything with the environment. And this is otherwise called wrench. That is rhythmic ictal non-clonic hand movement automatism, wrench. So it's there in Bradley. It is in one corner of the Bradley. So this actually automatism. It's not aura. It is not related with sensory other things. It is actually automatisms. So just keep in mind that such a question is there. Now about febrile seizures. You, even being a physician, you know, many pediatricians also will be aware of this. But even being a physician, after becoming a neurologist, since there are not much of pediatric neurologists, we will come across lots of febrile seizure cases or patients who have seizures who had previous history of febrile seizures. So it's very important to know about febrile seizures. So try to answer this question regarding febrile seizures. I think this question is directly from Harrison, so you should be able to answer it. It's pretty simple. Simple questions. These kind of sentences are there usually being asked in case of exams, especially NEET one. So patients definitely will be having family history. So any febrile seizure, if you ask, some family history will be there, and it will be not of an absence or focal seizures of preserved awareness. It will be actually a generalized tonic-clonic type. And seizure would occur only after the rising phase of temperature curve. It never occurs before the temperature curve. And that is the patient having fever, respiratory complaints, then later it develops. And it is actually a single brief isolated event and symmetric in appearance. We may have, because we are seeing lots of febrile seizure, we may think that febrile seizure is very common, and in a single patient itself, from 3 months, 6 months, 6 months to 6 years is the usual time period we think have in our mind. So the patient will be having recurrent febrile seizures maybe once in 3 months and all. It's not like that. The usual thing is that febrile seizures usually is a single event. About 30 to 40 percentage may have further seizures. That is just one more seizures. That is the usual studies which show. So it's very common condition, and it is most common seizures in child, and it's a very benign condition. And most febrile type, if some question has come, it is actually generalized tonic-clonic seizures. And they are typically symmetrical and last less than 15 minutes. If it's more than 15 minutes, we term it as a complex febrile seizure. And usually it should be only one seizure occur in a particular febrile illness. If more than one seizure occur in a particular febrile illness, then also we call it as a complex febrile seizure. And most affected children will not have recurrence of a febrile seizure in their lifetime. You should know all this, because once a patient comes to you, it's very important to classify it as a simple or a complex, because based on the typicality, we have to think of whether the patient is having any other undercurrent illness, whether we have to go for a lumbar puncture, whether we have to go for a prophylaxis with seizure medications, or febrile seizure, we don't usually go for MRI or EEG. So but in case of complex febrile seizure, definitely we have to think of otherwise. So complex febrile seizure have 3 criteria. So it should be more than 15 minutes. Focal features, if there, we should definitely be careful. And occurrence of more than one seizure in 24 hours or within the same febrile illness period. Then we have to think of a complex febrile seizure. So this is also very important, and this is because of a controversial thing in the clinical scenario, especially in case of pediatric neurology. This is a short question in the coming entrance. Now coming to the pathogenesis and pathophysiology, which is very confusing, and also these are kind of hypotheses. Since these are confusing, these you have these parts you have to concentrate and read. So these are actually decisive questions. So these kind of questions, if you make mistakes, your ranks could come down. And if you have studied everything, you may not reach or get the top 100 or top 10. So these parts, it is very difficult to keep your concentration tight. So even if I have put the question, read Bradley part. This question I had taken, I think, from Harrison, so that you don't miss the Harrison part of pathogenesis of or epileptogenesis. After reading Harrison, definitely go back to Bradley. So something called paroxysmal depolarization shift. As you know, there is hyperpolarization. There is a spontaneous hypersynchronous. That is, all the neurons are firing all together suddenly, causing this seizure activity. So why all neurons are causing this suddenly having this synchronous activity is due to something called as paroxysmal depolarization shift. So this occurs in a particular region of the brain. And after this occurs, this has to move or spread to cause a secondary generalization. So first thing is why this depolarization shift occurs. What is the mechanical phenomenon or the chemical, the ionic phenomenon behind this? So this is directly from Harrison. What do you think it is? Very confusing, I admit. So just to make you focus on this part of Harrison, I have put this question. So read that part. So magnesium, nobody, I think one person has answered. Nobody would answer or go back to magnesium since calcium is there. The answer is that definitely calcium has to go in. So calcium, influx of calcium is one of the things which occur. And also there is influx of sodium, which causes this. So hallmark. So what we see in an EEG, electroencephalograph, is called a spike due to the intense firing. So a single neuron cannot produce a spike. A large amount of neurons within a particular area, say 5 centimeter square part of the brain, will produce only a spike. So this occurs because of the bursting activity in the individual neurons, which occurs all together. And it is a long lasting thing. it occurs because of the influx of calcium, and which causes this sodium channel to open, and there is further entry of sodium channel, and that causes what you call potentiates after potential mediated by GABA or potassium. So after this thing is made, this has to propagate. This has to move around, spreading on to other neurons. So this kind of electrical activity has to spread to other neurons. That is made by these four mechanisms. So this you can just read. I had for your convenience, I had just put it in the slide. This you can read. So any problem in this? So if you see here in the third line, the NMDA receptors etc. are acting here. So if some problems occurs here, then there is actually continuous seizures going on. That is why you have this NMDA receptor encephalitis. So NMDA receptor encephalitis, that is autoimmune encephalitis, even AMPA acts. So other receptors, LGL, etc. acts, causes continuous encephalitis and problems just because of this problems affecting in this receptors. So regarding EEG, next class I'll be telling you regarding a few things regarding seizures for you to read the basics. Just a simple question. Yeah, I have talked to you about this in the first class regarding stroke itself, the same question, I guess. But just wanted to introduce back and also to the new listeners. So in the normal awake adults lying quietly with eyes closed, the background rhythm you see in EEG is definitely it's alpha rhythm. So no, it's not beta rhythm. Once you open the eyes, definitely there is beta rhythm. You have to remember one more thing. After being the eyes being closed, if you are not thinking of anything, or if you are just lying down with eyes closed, not thinking of anything, or not doing any mental arithmetic, then you get the alpha rhythm. But once you have something in your mind and you are like doing some calculations and all, slowly the beta rhythm will set in. And once you have, that is alertness, slowly, if you, even if the eyes close, if you start alerting your mind, the beta rhythm will come in. So in that question, you should be careful. I didn't want to confuse you. That's why I didn't put the change the question as such. And if you, once you open the eyes, this beta rhythm. So it was, alpha rhythm was the first one identified by Hans Bergen in 1929. And these rhythms are actually originating in the posterior occipital region. And mu rhythm is actually a variant. Mu rhythm is actually a variant. It's not a normal rhythm. So as we know, in this focal rhythms and generalized rhythm occurs, the absent seizures is actually a generalized rhythm. It's a continuous oscillatory rhythm. So where do you think this oscillatory rhythm originate from? Is it from the cortex, pons, amygdala, thalamus, medulla, etc.? What do you think? So this question, this answer has been taken from Harrison, one of the repeat questions. Yes. So this is basically from thalamus. Okay. So these are parts you have to learn. So this is, you can read from Harrison. So next things are actually few syndromes. So childhood onset syndromes I'll look into in the next class. So answer this question. In case of mesial temporal lobe epilepsy, what do you think is the right answer, which is not an MRI finding in it? Quickly answer, because one page has been dedicated and one table is there in Harrison regarding mesial temporal lobe epilepsy. Learn to draw the parts of hippocampus, cornu ammonis, etc. For your use. Yes, it's a pretty simple question. So I'll tell you something. So this is from Harrison table. So as you have seen here, it is actually enlarged because of there is temporal lobe atrophy. There is enlargement of temporal horn and not frontal horn. If you see here, this MRI, this is what MRI? Gray matter is white and white matter is dark. Gray matter is white and white matter is dark, and CSF is white. So this World War II, so water white in two. This is a T2 weighted image, and this is a flare image. This is the flare image. Here, this is the flare image. Here also, you can see that the gray matter is white and the white matter is dark. So this is just the T2 with the CSF cutoff. And you can see here, there is dilatation of the temporal horn. And there is also something called, this is actually the region of hippocampus. So sorry, this is actually the region of hippocampus. And there is T2 hyperintensities in the region of hippocampus here. So these are the findings in case of, so atrophy is there, temporal horn, temporal lobe atrophy is there, temporal horn dilatation is there, T2 hyperintensities are there. So these are the findings. So very important question, read and answer. You may think that I'll just warn you before you answer. So I don't want anyone to make mistake in this. That's why I'm giving you warning before answering this question. So please kindly read the question and answer. Read each, don't, yes, very good. But yes, only one person had made it wrong. I definitely don't want anyone to answer the wrong answer in this, but two persons have made it wrong till now. So these are the things. So we have been learning some questions like this for long. So we have been learning from long, even from a MPBS period regarding this HLA-B 1502 and antigen. In newspapers also we have seen, and it is notorious to cause skin reactions, especially in Asians. And we know about only single drug, that is carbamazepine, which is known to cause this thing. But other drugs can also cause these skin reactions, and this was also looked into with the help of HLA-B1502 testing. So this I took just, I didn't cross check much. I just took from Harrison this sentence. Carbamazepine, phenytoin, lamotrigine, and oxcarbamazepine in Asian population can cause, with this HLA-B1502 antigen, can cause skin reactions. And so valproate definitely will not cause. So that is the thing. And studies, so this is just taken from Harrison, this purely from Harrison. And specific for carbamazepine induced hypersensitivity, especially in Japanese population, is HLA 3101. So these are probable MCQs. So don't make mistakes in this kind of questions. Okay. Okay. So framing of questions may actually think you like that is the first option was given as carbamazepine. So don't jump and answer, read the question properly before answering. So this is also from Harrison. This is just I think this was the last sentence in Harrison in part of epilepsy, last sentence. So the ratio of drug concentration in breast milk. So we may think that because we are giving left in case of epilepsy, especially in case of female patients, left right, we are giving levetiracetam because we think it's safe. And after giving levetiracetam in a pregnant female, uh, after she delivers, we continue giving this drug. And the lady comes to us and asks us whether it's safe, whether it will be secreted in her breast milk. We say that definitely it's safe and all. But the actual thing is that about levetiracetam is the one which will have the highest drug concentration in breast milk relative to the serum concentration. But now the question is whether we should continue when compared to other drugs. Actually, we can continue because it's still the safest drug. Even though its concentration is more, it is still the safest drug when compared to others. In what percentage of pregnant females with epilepsy does seizure frequency increase? So as we know, pregnancy and seizures, pregnancy and multiple sclerosis, pregnancy and migraine, all are very important. Pregnancy and stroke, everything are very important topics. And at least one or two questions from pregnancy with all these neurological comorbidities is a sure question. So what do you think the answer is? This is also taken from Harrison. Yes. Actually 50% of the population will have the seizure frequency remaining unchanged, but 30% will have their frequency increasing, and 20% will have a decrease in frequency. And definitely fetal abnormalities will be more in 5 to 6% on those who are taking anti-epileptic medications. So what is the definition? So now we have seen seizures. So when the seizures are prolonged beyond a certain period of time, we term it as status epilepticus. This is a very dangerous condition because we have to immediately act. So what is the definition of status epilepticus? What do you think it is? Seizures that persist for a sufficient length of time uh, and becoming fixed and enduring condition. Seizures that persist for a sufficient period of time and there is no recovery between the attacks. Goes beyond more than 5 minutes of continuous seizure activity, or it is 2 or more discrete seizures between which there is no incomplete recovery of consciousness, or the answer is none of the above. What is the latest definition of status epilepticus? Just like we learned what is the definition of seizures, hope you remember it. If not, just revise. And like that, I want you to remember this definition of status epilepticus. That is why I have given this option. So even if you don't know, just try to attempt and make it wrong, because this is the place where you can get it wrong and then revise, correct yourself, and correct it during your actual examination. So attempt for sure, those who are listening to this session. Okay, good. Very good. So it's actually the latest definition. All these statements given were definitions of status epilepticus at particular periods of time. That is 1981, 1989, 2001, etc., etc. So, but the latest definition is actually it almost mirrored, almost was similar to what the seizure classification was there. But the latest definition is not based on all these. The latest definition is based on something which is very much more complex. So it was given by ILAE task force. You needn't by heart all this, but you should understand that it is based on the mechanism responsible for the initiation of seizure and why the seizure was not able to get control. That is why what caused the seizure termination could not occur. So it was based on 2 points, that is T1 and T2. By now you must have heard of this actually. What is T1 and T2? So just the definition is conceptual and it is based on 2 time points, that is T1 and T2. So everybody, some people had messaged me what is the actual definition of status epilepticus. There is actually not proper definition of status epilepticus. In case of convulsive status epilepticus, both time points T1 is actually 5 minutes and T2 is 30 minutes are based on animal experiments. So the actual definition right now is something like looking like this. So if it goes beyond, so T1 is the time when seizure is likely to be prolonged, leading to a continuous seizure activity. So seizure, as you know, it's usually subsides within 5 minutes. So after 5 minutes, that is the T1 period. And after 30 minutes, we call it as, it is not actually, after 5 minutes itself, we can call it as status epilepticus, or it can call it as early status epilepticus. And once it is beyond T2, it is the time when these seizures can cause severe neurological death, neuronal alteration, and functional deficit. So for all this, you have to learn. For tonic-clonic seizures, it is 5 and 30. For focal seizures, it's 10 and 60. For absence, it's 15 and it can go infinitely, or it is unknown. So this table you have to learn. It could be coming for your entrance because this is the latest classification of status epilepticus and it has not definite time period. But super refractory status, there is a time that is 24 hours. But status epilepticus, they are now based on T1 and T2. So all those have asked me in questions like ask queries in WhatsApp and Telegram for them. So what happens is that there is actually when there is an imbalance between excitatory and inhibitory neurotransmission, there is chloride exit, and after that the seizure activity starts. So these are actually GABA channels. These GABA channels are there. So initially when this GABA channels are activated, so this glutamate is the one which is excitatory, and GABA is the one which is inhibitory. But what happens is that once the seizure starts, because of this continuous seizure activity, these GABA channels become deranged. And once the GABA channel becomes deranged, and there is some internalization and some changes which occurs in this channel, even the GABA cannot act, and even the benzodiazepines which we give as the initial status epilepticus management, if we do not give in the initial period of this seizure status epilepticus, if we give after some time, these also won't act because these GABA channels are actually deranged. You can see the deranged GABA channels. So that is the importance of treating status epilepticus and identifying it early. That is the need why they have put this T1 and T2. And status epilepticus is not just beyond 30 minutes or 1 hour. It's actually T1 and T2, and T1 and T2 times we have seen. And refractory status is seizures that persist after 30 minutes for generalized seizures, 60 minutes for focal seizures. And you should always think the use of two anti-epileptics. One is a benzodiazepine and one could be a anti-epileptic drugs. These are the usual thing. And previously it was thought that there is no time period. Just some people had told there's two anti-epileptic drugs not getting control, one phenytoin and one benzodiazepine. But this is the usual thing followed regarding refractory status. And this is super refractory. This is a repeatedly asked questions regarding super refractory status. It's actually 24 hours because this is the one which has a specific time period, that is 24 hours. And somebody has asked a question regarding super refractory. So super refractory I have defined as status epilepticus that continues or recurs 24 hours or more after the onset of anesthetic therapy, including those cases where status epilepticus recurs or reduction or withdrawal of anesthesia. So this is actually regarding super refractory beyond 24 hours. That is the maximum you need to know. So classic lissencephaly. So there is a table in Harrison. You have to read it by heart. Lots of questions could come. So 3 questions I have made from it. Classic lissencephaly with the severe mental retardation. Only if you have read the table, you will be able to answer it. So these 3 questions I will, question number 18, right? Question number 18. Okay. So try to answer this. So last few videos I have kept. So be there till the last. Okay. Yes, very good. Those who read the table will be able to answer it. Yes, it's X-linked recessive. Yes, X-linked recessive. So just to see, I have marked the table important points, but you should mark yourself. Just see. So LGL1 gene is associated with which of the following syndromes? This is similarly from the table itself. So question number 19. Okay. Okay. Try to answer. What do you think this gene is associated with? Yes, those who have read are answering. Yes, it is autosomal dominant partial epilepsy with. So these are all difficult things if you don't read. So just a single table will be able to give you answers or help you answer in the exam if you study. So this is a high yield table. So don't mark it and read it. Read it. And the identification of SLC2A1A mutation, which encodes GLUT1 and causes GLUT1 deficiency syndrome. So in case of such a syndrome, what should we go for? Should we go for an epilepsy surgery? Should we go for sodium channel blockers, ketogenic diet? Or should we go for cannabinoids? What do you think? if a patient is found to have GLUT1 deficiency syndrome, immediately we have to start them on keto diet, because otherwise the syndrome, the seizures will aggravate and the patient will go for status and other neurological deficits. So most probable questions, which these are just from Harrison. So these are all probable questions. This was asked in the previous AIMS, I think, not this this AIMS, previous Sri Chitra, I think. Yes, this was asked in Sri Chitra. SCN1A should generally be avoided. So this occurs in case of Dravet syndrome. So Dravet syndrome should generally be avoided while taking phenytoin or lamotrigine. That is because these are sodium channel blockers. And whereas patients with mutation in SCN2A or SCN8A, sodium channel subunits, appears to ref. So if you check these mutations and if you find these kind two, and if in your question these two mutations are positive, we have to treat the patient with high dose phenytoin. But if you find this SCN1A, then we shouldn't treat, because it will aggravate the seizures. And ALDH7A1 gene, you have to treat with high dose pyridoxine. So know that. And autosomal dominant nocturnal frontal lobe epilepsy is due to mutation in which gene? So this is question number 21. Okay, so okay, so just I put these three questions from the table so that you will emphasize on the table. Now this is a video question. The EEG shows diffuse gene waves with chaotic background of irregular multifocal spikes and sharp waves. So with this chaotic background in the question itself, you must have come to an answer. But before that, I'll just show the video of the child, video of one child. So you can write in the chat what do you see? Yeah, these are actually salam attacks, but these are actually continuously, these are kind of occurring as a epileptic status. So that is the other thing. So I didn't put the polls, I guess. Question number 20. Okay, launched one. Okay, so simple question. Now last, so that was the thing. So what is the diagnosis in this case? See this video and try to answer. So first I won't give you any diagnosis, any history of the patient. This is roughly around 60 years, 15 to 16 years female child. What is the semiology? Do you see? What semiology do you see? So mother is just now commenting that she was actually behaving as if she is from a different world. Her word output had decreased. She was using only single words, and her behavior has changed over past, I guess, 1 to 2 weeks. And so I'll launch poll. What do you think it is? Won't give any history. This is more than enough. So what you see in this patient is actually facio-brachial dystonic seizures. Facio-brachial. Face you can see. Face movement you can make out, right? So facio-brachial dystonic seizures. Brachial, right upper limb. And patient is having behavioral change and other symptoms. and patient also has having ovarian teratoma. So this is actually a case of NMDA encephalitis. Patient was NMDA positive. She was given IVIG initially and later had to be given rituximab. It is not focal dystonia. It's actually dystonic seizure. It is an autoimmune. It is not pseudo seizure. All she was initially treated by psychiatrists, thinking that since she was having psychiatric manifestation initially, she was thought to be having not pseudo seizure, psychiatric problems, and was treated with antipsychotic medications. So all these autoimmune disorders, you have to have a high index of suspicion, especially in early stages. Even the EEG, I think I would have discussed. EEG will be having delta brushes. It is not normal delta brushes. It will be extreme delta brushes. That is delta range of slowing with brush-like activity in the top of it, which we will discuss in the next class. So this is actually autoimmune encephalitis. So this is the same patient after treatment. This is the video she sent to me after, I think, 2 months. She is actually a YouTuber making videos. So she is intellectually preserved even after having prolonged seizures. So this is the benefit you get of properly identifying autoimmune encephalitis and treating. Her ovarian trauma was also removed. So next class we will study about localization based on the aura, few things, EEG basics, different types of important seizure semiology, which will be asked in the next exams, drugs in seizures and treatment management, because last NEET treatment of status was asked. SUDAP is important, could be asked in the recent names. Epilepsy surgery, one or two questions we will see, and epilepsy syndromes. That is Lennox, Gastaut, West, Beck's, JME, etc. Few syndromes we'll learn. So I think this session was useful for you to read the Harrison and Bradley. So epilepsy, it's very tough. So try reading Bradley. So any doubts you can message me because in this video session it's very difficult to answer. I saw some people raising their hands. I can answer you in my mobile. I think you all have my mobile number and or WhatsApp. Telegram group is this. I have given WhatsApp group. WhatsApp group is already full. WhatsApp you can WhatsApp me in that WhatsApp group. A bit busy these days. Sorry for that. Okay, so I think we'll wind up the session. Thank you. Vinayak will stop the session. Thank you.
Yes, sir. Yes, sir.